Today's lecture is not about the basic signs and symptoms. We are going to shift our topic from signs and symptoms towards management. I hope you have already dealt with the symptoms and pathophysiology of infarction in your pathology module of this week, and now I'm here to discuss with you about the management. As you already know that infarction is basically the death or the necrosis of the tissue. It is the death of a part of a body or an organ of a body, and you might consider the effect of on the physical as well as psychological thinking of a patient who is suffering from infarction or gangrene or necrosis of any part of the body. That is, you might have a healthy individual with a dead heart, or you might have a healthy individual with a portion of the brain dead, or you might have a healthy individual with a part of a limb which is dead. So it's not just the physical appearance or the functional ability of the organ which is disturbed, but it's also the mental capacity of the individual to cope with the stress of this dead tissue. The purpose of this today's topic would be to give an adequate knowledge about what options do we have for the individuals who are suffering from infarction, ischemia, gangrene, necrosis. What options do we have to salvage the organ or to salvage the part of the body, and to explain the diameter of the disease, the extent of the disease. It's not only a portion of the body which is dead. A lot of molecular signaling and a lot of organs are interconnected with each other, and thus the capacity of other organ systems is also affected. We'll know about that in short detail, and in the end how to manage the ongoing insult of the tissue, how to prevent a tissue which is at the danger of ischemia or gangrene or necrosis, how to prevent it, how to salvage it. By definition, the infarction or necrosis are the one and the same thing, and it is due to the disturbance in the blood supply to a certain part of the body or certain organ of the body. Now you already know that the part of the or the organs of the body are supplied by two major vascular components, the arterial and the venous, and it is the arterial system which is responsible for providing the nutrients, oxygen, and the important components, the minerals and vitamins to the body, whereas the venous system is basically meant for the drainage, and it takes away the waste products as well. The death of the tissue or infarction might be due to the blockage of the arterial system. Therefore, the organ or the tissue which is affected will not get the proper oxygen and the nutrition and ultimately dies. It might also be due to the venous blockage. Yes, the venous blockage, when happens, would increase the pressure over the diseased organ. The backward pressure increases and causing edema and cell swelling, resulting in compromised arterial supply as well. Therefore, we can get both components of the disease, or the spectrum may vary from arterial to venous end depending upon the type of etiology and the effect which is produced. So if we are going to further classify the infarction varieties, there are two major components, whether the infarction is due to the blockage of the blood stream to a certain part of the body, or it is due to the excessive spillage before reaching a part of the body, or accumulating the spillage into the portion of the body which need to be perfused. Among the ischemic types, what happens is that we are going to have a blockage somewhere in the entire stream of the blood flow, as this is the portion which is showing that the lumen of the vessel is blocked, and this vessel lumen is blocked due to the underlying accumulation of this fat, that is the atherosclerosis, and further deposition of platelets and fibrins over it, resulting in the blockage of the vessel, and ultimately the blood supply to that portion, the portion which is distal to the blockage is compromised, and therefore when the blockage or the arterial supply is compromised, the organ system or the organ itself will get shrink and die of hypoxia and lack of nutrition. Whereas in other case where the portion is suffering from the loss or spillage of the blood, this type of infarction occurs when the important vessel or major vessel supplying the organ gets disrupted, broken down by trauma or some other process due to connective tissue disease, or might be due to coagulopathy as well. And ultimately what happens is the blood spills out of the vessel, it gets accumulated in the nearby tissues. The spillage of the vascular compartment will not only reduce the vascular volume but also would exert the pressure on the surrounding areas, resulting in the compromise of the capillaries and the end arteries within the cell itself, and thus predisposing the organ or a portion of the body to gangrene. Which part of the body is prone to it? Almost every part of the body is prone to ischemia, and infarction can ensue in any part of the body. However, we will be dealing with the major portions, the major organs like the heart, brain, lungs, spleen, limbs and bones. We will deal with it one by one. The most common and the most encountered emergency in the emergency department would be the compromised circulation of heart. It is the most fearful complication that an individual might experience in his or her life, with the presenting complaints of chest pain, sweating, chest heaviness, and ultimately turned out to be something related to the vessel of the heart. The coronaries, the coronary arteries which supply the heart, which supply the myocardium with blood during the diastolic phase of cardiac cycle, get compromised due to the atherosclerotic plaques. The dyslipidemias resulting in the formation of plaques within the intima of the vessels, causing the narrowing of the blood supply, as you could see over here in the figure. The blood supply is compromised over this portion, and further compromise or further blockage will ultimately lead to the stenosis and occlusion of the vessel. However, sometimes the overlying thin layer of intima breaks, and the presence of lipids and the collagen underneath would activate the platelets within the circulation, causing or forming the platelet plug over the diseased area and further narrowing down the lumen and compromising the blood supply. What we can offer to that individual? A patient who is suffering from acute coronary syndrome, that is the syndrome which emphasizes or which describes the loss of the blood supply to the coronaries, inadequate blood supply to the coronaries, inadequate oxygening of the myocardium, that can be countered with some of the maneuvers like antithrombotics or anti-anginals. The purpose of the reperfusion or maintaining the perfusion or salvaging the myocardium is to prevent the area of the myocardium to get diseased and to restore or to maintain the originality or contraction of the myocardium. So the individual who is suffering from myocardial infarction or the damage to the vessels of the heart would be suffering from pain, and therefore he or she requires analgesia, which is usually given in the form of morphine or nitrates. Next is the thrombosis. The thrombosis needs to be retarded, slowed or stopped, and for that we have options available like the antiplatelet drugs, among which aspirin and clopidogrel, dipyridamole are commonly used. Loading an individual with antiplatelets and followed by anticoagulants. The difference in management of ST elevation MI and non-ST elevation MI is beyond the scope at this level. However, you need to understand that we need to block the formation of platelet plug, plus we need to disrupt the platelet plug already which is developed over the area. And for disruption of that plug we need anticoagulants or thrombolytics. Among the anticoagulants, heparin is used, and among the thrombolytics, streptokinase, alteplase, tenecteplase or TPA are used. Then comes the role of anti-anginal agents. The anti-anginal agents are beta blockers, calcium channel blockers or nitrates. They are there to improve the blood flow to the diseased coronaries, not only before CABG, that is the bypass grafting, or before stent placement, but even after the CABG and stent placement, the anti-anginals have a role. The anti-anginals tend to keep the vessels patent and open to allow maximum oxygenation of the myocardium. Reperfusion therapy refers to the targeted therapy which is used to open up the vessels either by a stent placement within the vessel or by thrombolytics like the tissue plasminogen activator, tenecteplase, alteplase, streptokinase, or by replacing the vessel, diseased vessel, with a graft from a vein like a greater saphenous vein or from an artery, internal mammary artery, and the procedure is known as coronary artery bypass grafting, CABG. The next organ is the brain. Like the heart, the area of the brain which gets diseased or which gets necrosed or gangrenous or infarcted will not get repaired. And among these compromised blood supply to the brain, the clinical condition known as stroke or cerebrovascular accident, CVA, the underlying etiologies or the blood supply compromise etiology is divided into two major categories, whether it is arterial stroke or it is a venous stroke. 99% of the strokes patient, they are arterial. Out of these arterial stroke, 85% are those which are infarctive strokes and 15% are those which are hemorrhagic. By infarctive stroke we mean the individual's blood supply supplying the portion of the brain is blocked by a thrombus. The blood supply is totally cut off. Whereas by hemorrhage, it means the vessel is disrupted, ruptured, and the blood oozes out from the vessel into the surrounding tissue, and the subsequent area is compromised. So among the cerebrovascular accidents, as far as the epidemiological data is concerned, more of the stroke are due to the arterial causes, and among the arterial causes, the major portion is that of infarction than that of hemorrhage. Now, what could we offer to a patient who is suffering from this arterial stroke? The portion of the vessel or the artery is blocked. If it is ischemic, what options do we have? Just considering the underlying pathophysiology, the same pathophysiology that is of dyslipidemias, thrombosis and occlusion of the arterial vessel. Therefore, we need something which is there to thin out the bloodstream, like aspirin. We need some agents which are going to reduce the level of lipids in the blood, that is the statins, torvastatin, rosuvastatin, simvastatin, and so on. We need some agents which are going to control the risk factors of stroke, like hypertension, if a patient is suffering from hypertension, or underlying diabetes, we need to control the diabetes. Smoking, a major risk factor for stroke, needs to be countered. And yes, as in the case of the cardiovascular system, we have some thrombolytics in place, the reperfusion therapies. Similarly, In the cerebrovascular system, we can also deploy these thrombolytics or interventional agents. Tissue plasminogen activator have a successful trial among the cerebrovascular accident patients due to the ischemia or infarctive stroke, not in hemorrhagic strokes. And the tissue plasminogen activator, if given within about 4.5 hours since the onset of symptoms, would reperfuse the area effectively and prevent the damage or limit the damage which is to be happened in the stroke patient. Other options which we have are the placement of endovascular stents in the cerebral vasculature to open up the narrowed vessels, but that's also time bound and we cannot perform it after a day or two. It is usually beneficial in the initial stages. This is how CT scan, the investigation is CT scan of the brain, and on the left half of the screen, this portion is showing a normal brain CT, whereas among the this is the on the right side, the portion with the dark lesion on it, which is not consistent with the consistency of the not consistent with the consistency of the rest of the brain parenchyma, is suggestive of ischemia or infarction on that side. This is due to the blockage of the vessel supplying the blood to this portion of the brain, and this is an ischemic stroke, or this stroke is due to the blockage of the blood supply to that portion of the brain. Now what happens in hemorrhagic stroke? The vessel disrupts, the blood pools out of the vessel and it gets accumulated within the brain parenchyma, increasing the pressure within the cells, causing compromise of the nearby small vessel circulation and also compromising the area which was supplied by that vessel. This is how a hemorrhagic stroke appears on a CT scan, and this is an post-mortem view of the brain with the hemorrhage and blood clotted into the brain parenchyma. You can see the difference between the CT appearance of a hemorrhagic stroke as compared with an ischemic stroke. Now in cases of hemorrhagic stroke, what options do we have? We are not going to give blood thinners obviously in this condition. We are going to target the underlying etiology or the underlying risk factors, which are almost the same except for the coagulopathies, which would lead to hemorrhagic stroke, not the ischemic strokes. And the main aim of management in the hemorrhagic stroke would be reduction in the raised intracranial pressure to maintain the GCS and to avoid further damage to the brain. Now, although rare, but yes, the venous system might also get affected in the conditions of cerebrovascular accidents, as 99% of the CVA or stroke are due to the arterial ischemia, but about 1% are also due to the venous blockage. Now this is the on the upper left, the diagram shows the normal sinuses in the brain, and this is the venogram, and this the middle area of the picture shows us a CT scan of the brain with somewhat abnormal pigmentation on this part. This is actually the extravasation of blood after the blockage of the vein and increased back blood flow. This is how a venous infarct would look like. Similar individual, similar case, but the image here is the T2 MRI and the FLAIR MRI brain, showing the appearance. On the lower left corner is the gross appearance of an individual, the post-mortem appearance of a brain of an individual suffering from a venous infarct. You can see the bilateral involvement in this, a diagrammatic representation of a thrombus in the vein, the absence of the venogram here, the absence of the venogram here, no venogram visible on the right side of the individual. You can see the cord sign, clot within the vessel. This is just to show the appearance of the CT or MRI with an individual with a venous infarct. Now, how will you manage acute cases of stroke? Apart from the etiology and the targeted management, you need to manage the other aspects like the prevention of the ongoing complications which might develop in the due course, and stabilization of the patient is a priority. Therefore, the management starts right away from airway management. The the individual who is suffering from stroke is not in a well oriented state, and he or she needs his airway to be maintained either by head tilt or chin lift maneuvers or turning a patient to one side in order to maintain or the adequate oxygenation of the rest of the body. Breathing is to be maintained, and the breathing capacity depends upon the respiratory rate and saturation here. Next comes the circulation, adequate perfusion of the body, the adequate perfusion pressures, adequate hydration is mandatory with IV fluids. Nutrition, as the individual is in a semi-conscious state, he or she might be able to take the food or the nutrients himself, so might need a foreign aid like placement of a nasogastric tube and the delivery of calories through that nasogastric tube. Medications are to be given via IV route or intramuscular route. The risk factors, blood pressure, blood glucose are to be monitored and maintained. Temperature, fever. Usually the fever in the CVA patients is not due to some underlying infection, or it is actually the sequel of the stroke itself. However, among the poor prognostic factors, fever is present among them. Other poor prognostic factors are desaturation of the patient, that is, oxygen saturation is not maintained, or hypoglycemia in an individual who is suffering from stroke, and dehydration. So hydration, temperature, hypoxia and hypoglycemia, these are the four major parameters which are to be maintained in an individual who is suffering from stroke to prevent the further progression of the stroke and to restore the circulation of the affected area. Then comes the pressure source. An individual who is suffering from stroke would be bedridden now for at least for 10 to 15 days. Till then he might receive or might require the help of the attendants or the physiotherapists or the nurses to move the body from one posture to another, to help him sit on his couch or to get up off the bed, and therefore major portion of the time would be spent by that individual on the bed, and resultantly the pressure will be applied over the dependent area, and if the posture change is not done every hourly or 2 hourly, the affected area gets compromised, the circulation at the back, at the lower back especially, gets compromised, and resultingly a sore or an ulcer develops, which is known as a bed sore. That is an area of infection as well, an iris for infection, and might worsen the underlying prognosis. Incontinence, sometimes the individuals with a stroke suffer from fecal or urinary incontinence, and to counter that you need to catheterize the patient. However, the presence of indwelling catheters is a source of infection as well. and mobilization. Among a few diseases of the human body, this is one of them in which bed rest is not advisable. Now let's move on to the other organ system, that is the pulmonary system. The pulmonary infarction or the lung vessel compromise would result in a damage to the lung. The individual would present with chest pain, hemoptysis, shortness of breath, may or may not be having fever, and the thrombus, which is blocking the vessel of the lung, usually is traversing, or the embolus is originating from a deep leg vein, DVT, deep venous thrombosis, and ultimately this clot gets lodged into the pulmonary veins. From deep leg veins, it's moving up through the inferior vena cava to the right ventricle, and then to the pulmonary vein and into a small vessel, or according to the size of the embolus it might block a major vessel as well, like a saddle thrombus in the pulmonary trunk, and ultimately causing blockage of the pulmonary veins. And the blockage of the pulmonary veins would result in compromised blood supply to the lungs and causing damage or ischemia or infarction to that portion of the lung. This is how the lung damaged area would appear. Wedge-shaped opacity on chest X-ray, typical of the underlying vascular compromise and pulmonary infarction. Here it is shown in this is the HRCT, high resolution CT scan of the lung, showing a portion which is damaged due to the compromised blood supply and underlying atelectasis. This is how a post-mortem or a gross examination of the diseased or the infarcted lung would look like. What we can offer to that patient, apart from maintaining the airway and the breathing of the individual by the helping out the hypoxia with supplemental oxygen, or bypassing an endotracheal tube and attaching the individual to the ventilator. Rest of the measures depend upon the underlying etiology. The blocked vessel is to be opened up. The coagulants need to be antidosed, and therefore again comes the role of anticoagulants here, like heparin, unfractionated or low molecular weight. Other than the anticoagulants, we can use the thrombolytics here as well, like streptokinase or TPA. And in case of a large thrombus or an embedded thrombus or lodged thrombus, you might need surgical help to open with an open surgery and removal of the clot. Caval filters are actually the facility. These caval filters, these are actually the filters, an umbrella shaped coil which is implanted or placed in the inferior vena cava through the femoral vein to avoid the dislodge of the thrombus or the embolus from deep veins to the right ventricle. It actually blocks the embolus and traps the emboli which are moving from the legs towards the lungs. However, caval filters are not routinely used. They are the alternatives for an individual whose pulmonary embolism is due to the deep vein thrombosis, and the individual also cannot be given anticoagulants or thrombolytics due to some other comorbidities. After target management, we are going to give the general supportive care with fluids, increasing the perfusion pressure and giving oxygen to the patient with a face mask, nasal cannula, or via mechanical ventilator. Overcoming the pain with opioids. And among the anticoagulants are the heparin and the vitamin K antagonist, that is the warfarin. Careful candidate selection is required for thrombolytics and surgical therapies. Thrombolytics are only given in individuals where there is a massive pulmonary embolism and the individual is suffering from hypotension due to the pulmonary embolism. And surgical therapy is still reserved for those who are not a candidate for anticoagulation, long-term anticoagulation. Now the other organ which is at risk might be due to arterial ischemia is spleen. Spleen itself is working as a sequencing for the end of the blood vessels and also for combating the infections. However, it's not a common practice to see a splenic infarct individual. However, you might encounter one, and this is a dangerous complication of spleen. And the splenic infarction usually is in the non-infectious causes. The approach to the treatment or the management algorithm consists of painkillers, the analgesics, hydration, and supportive care. You might encounter these splenic infarcts among the sickle cell anemia patients, and sometimes from the septic emboli from the heart might traverse the splenic circulation and blocks the sinusides. In case of road traffic accident or traumatic splenic injury, surgical evaluation is required with a careful decision between splenectomy and conservative strategies. Next comes the limb ischemia, encountered in individuals with peripheral vascular disease like diabetics or smokers. And the famous P's of acute ischemia are the painful, pale, pulseless, perishingly cold, paresthetic, and paralytic limb. This pain is actually severe in intensity with loss of coloration of the limb. The limb is totally pale, and on examination you can easily differentiate between a cold and numb limb from this other limb which is totally warm and painless. And this acute ischemia needs to be dealt with in early, otherwise once the gangrene sets in, no intervention would going to help or salvage the limb, and amputation would be the answer to that. An easier classification of this peripheral vascular disease is the Fontaine classification, which describes the different stages of ongoing ischemia. For the starters, the individual might have no symptoms. It's very difficult to differentiate between Fontaine classification asymptomatic from a normal individual, practically not possible. The first most common symptom would be intermittent claudication. That is, the individual would complain of pain in the limb after walking a certain distance. The individuals get a hint of how much distance they could travel without pain, and the distance is known as claudication distance. And as the claudication distance decreases, the severity of the underlying blockage of the vessel is increased. Next stage would be without movement pain at rest. This symptom is more frequently observed by the affected individual during night or during sleep, when the limb is in the anti-gravity position, and the individual would wake up of the pain and would not be able to bear the pain and would not be able to stand on the limb for a while. However, hanging the limb down from the bed would help him to relieve or decrease the severity of the pain. This is an indirect hint of ischemic limb pain. And if this pain at rest is ignored or is not properly or promptly treated or diagnosed, would result ultimately in gangrene of the toe, arterial ulcers, gangrene and necrosis, and ultimately amputation would be the answer. How to manage this management of acute limb ischemia lies within the domain of a vascular surgeon. The early intervention by vascular surgeon before the gangrene sets in would help to salvage the limb. However, if the vascular surgeon facility is not available, or the individual needs to be transferred to a facility, meanwhile the individual could be given anticoagulants like heparin to control the ongoing ischemia, ongoing fluid aggregation, and to reverse the already devastating cascade of the coagulants. Other supporting measures like hydration and correction of hemoglobinopathies is supportive as well. Last but not the least is the necrosis of the bone. Not much encountered in general practice. However, the orthopedics or the dentists would encounter this necrosis of the bone due to the blockage of the blood supply to a certain portion, resulting in pain on the area and ultimately destruction of the bone and fractures. It's quite painful, and therefore you need to give painkillers to ease down the pain, and sometimes need to relieve the pressure by removing a portion of the bone. So as far as the medical management is concerned, you need to give NSAIDs and the thinning out the blood to make the bloodstream flow smoothly, and antiplatelet drugs might help with that. Apart from them, statins or the cholesterol lowering drugs would help to pave the way for the blood to reach the target organ. Among the surgical options are the osteotomies, that is the formation of some cavities within the bone to reduce the pressure, replacement of the bone to replace the diseased part with a new bone in place, that is the bone grafts. Thank you.